Now, Dr. Elaine Bullock, who is one of our chief residents, is going to make a presentation today. For the students, each of our graduating residents, third-year Peds and fourth-year Peds residents, required to do a grand round. So they pick a subject, they work with the mentor, and so Dr. Bullock has picked this subject to sleep or not to sleep.
Thank you, Dr. Bocchini. Okay, so we'll go ahead and get started. Can y'all hear me? I changed where the mic was. You can still hear me, Dr. Keel? Okay, all right. So we'll be talking about sleeping or whether you want to choose not to sleep. So like Dr. Bocchini said, I'm Elaine Bullock. I don't have anything to disclose relating this topic. My objectives for today are going to be to recognize the American Academy of Pediatrics recommendations for sleep based on the various ages, to define sudden unexpected infant death and discuss the preventative measures that we can do, to practice safe sleep habits, and to describe various different sleep methods to help educate our parents on how to get their little ones to sleep at night. And as most of the residents know, we really care about our American Board of Pediatrics board content specifications. I pulled the ones that were just related to sleep, and so I found 3 there, so this talk will be helpful for our boards. So you need to be able to identify the risk factors associated with sudden infant death syndrome, be able to counsel parents regarding preventative measures of sudden infant death, and then to understand the normal developmental progression of sleep patterns throughout age. So we're going to start off by talking about infant sleep. Don't know where we'd be if we didn't start off talking about SIDS. So this is actually sudden unexpected infant death. This was created by the National Center for Health and Statistics to help categorize and track SIDS and the other sleep-related infant death causes. So the definition is any sudden or unexpected death in infancy. Under this umbrella now is SIDS, so sudden infant death syndrome. You can have asphyxia, suffocation, entrapment, infection, ingestions, metabolic diseases, trauma, arrhythmias, and other cardiac channelopathies. There are 3,500 sleep-related infant deaths annually, which is a lot. Some of the studies I was reading, the non-Hispanic African Americans and the American Indians have double the rate of sudden unexpected infant death syndrome when you compare it to the non-Hispanic white infants. And the lowest risk is among the Asian and Pacific Islanders. And this can be correlated because they did a study, the Pregnancy Risk Assessment Monitoring System did a study, and where they sent out surveys to parents, and 80% of whites and 54% of African Americans placed their infants supine, even after they were educated by their pediatrician to not place them on their bellies. So 90% of these occur before 6 months of age, and the peak is between 1 to 4 months of age, which is when everybody's completely exhausted raising a child. So it's important for us to give the education. So we're going to talk a little bit about SIDS more now. That's under the category of sudden unexpected infant death. SIDS is when the death cannot be explained by any other reason. Our current understanding is that it's probably more multifactorial. So this is a diagram that came out of Peds in Review that shows that it's got a bunch of different things that can play into it. So the exogenous stressors would be placing them prone, overbundling, putting like any type of airway obstruction, if you cover their face with blankets or using too many soft objects in the bed would be a stressor. Critical points of development, that would be if it's an immature or dysfunctional cardiorespiratory arousal system in the infant. And a vulnerable infant is one that they think just has failed intrinsic protective responses, which could be genetically determined, maybe a delay in maturation or something like that. Some infants with SIDS have actually been determined to be like preterm, or they're small or interuterine growth retardation, so maybe they have not developed these protective responses, so they're more vulnerable than others. In 2013, which was the last set of data for this, SIDS, which is the component of the sudden unexpected infant death syndrome, was 46% of all of the cases, so it's still very high. And interesting, in one of these studies that I had read, and I think there's going to be more on this, is that there's a lot that has to do with serotonin in the brainstem. So in autopsies of children that were diagnosed with SIDS who had no other cause, they had decreased serotonin receptor binding, decreased transporters, decreased amounts of serotonin in the tissue. And so they're wondering if that could play a role in it. And so when they tried to, I guess, model this in rat models and they decreased the amount of serotonins, they had a diminished response. The rats did to like carbon monoxide, heat over heat production, and altered sleep architecture. So, with it being 46%, how can we reduce the risk of sleep-related deaths in our infants? So, back to sleep. So, the Back to Sleep campaign started in 1992, which is when they said, okay, everybody needs to sleep on their back. You need to place their infants on their back, not their side, for every sleep until the child is at least 1 year of age. After this campaign started, let's see if I can get this little thing to work. So when the campaign started in 1992, it dropped 53% of the sudden infant death syndrome rates just by telling people to put their kids on their back to sleep. But from 2001 to 2008, it kind of remained stagnant and remained the same. Even though we had dropped it by 50% in 2013, there was, just from SIDS, there was 1,500 cases in just that year, making it the leading cause of post-neonatal mortality. And so in this campaign, they were saying that the AAP Committee on Fetus and Newborn states that the preterm infants need to be supine for sleeping, especially if they're over 32 weeks of age. So that's something that we should be doing in our nursery and our NICU, because that we're modeling it for the parents. So we can't tell the parents, oh, they sleep on their tummy here, but when you go home, put them on their back. You know, so we need to be an example for them and show them that. And so once they turn 32 weeks of age, you know, they're able to, and obviously they're not on ventilators and a bunch of things, they should be placed on their back to sleep every time. So where do we want to put the infants to sleep? So they need to sleep on their own bed, their own firm, flat surface with only a fitted sheet. And you want to make sure that the mattress fits into the bed, so that way they can't find a little area with a shorter mattress where they can get impinged between the mattress and like the bed rails. You want to avoid bedding, bumpers, and other soft objects, which we'll talk more about on the next slide. And you want to make sure the crib is up to the safety standards. There's a whole group, the Consumer Product Safety Commission standards on cribs and bedside sleepers, which are these. These are bedside sleepers. These are in-bed sleepers, but there's studies underway, but there's no set recommendations on the safety that needs to be of those yet. There's no recommendations. And so we need to make sure that the crib's up to safety standards. You want to tell them not to use a broken crib, all right, or a crib that they might be borrowing from someone that we don't know if it works. If they're worried about that, pack and play can be $40, and that's pretty safe, and it's new. You know, from experience, I've got a crib for my grandfather for my first child, and it was missing pieces, so we didn't use it. But it's easy to say, oh, I'll just use your crib, but there's definitely safety standards that go along with the new cribs and why they are the way they are. You want to, these mesh pads, which are right here, which I thought were pretty cool. So this is the mattress. It's got a mesh pad on it, and so they advertise that they reduce the risk of SIDS, but there's actually no studies that prove that. But there's no disadvantages to using it. So this is what they advertise, that if the baby does land up on their belly, that they can rebreathe through the mesh mattress and they're not going to suffocate on it. And so you don't want to place the infant near any free cords, wires, or anything that can strangle with. So not by a window where there's like drapery, cords hanging down. And we need to tell our parents that car seats, strollers, swings, and slings are not recommended, because infants, especially those less than 4 months, can occlude their airway in those types of positions. And of this, it's important to know that it's a flat surface. There's no studies that show that elevating the head of the bed reduces the risk of GERD or helps with symptoms of GERD. There's no studies that show that they're going to be at increased risk of choking or anything on their reflux, unless they have some type of predisposed anatomic abnormality like a cleft lip. We need to put them flat, because if you raise it up, the kids roll down, and then they can get stuck on something or head entrapment on something. So soft objects, we need to be telling our parents to avoid the cute pillows and quilts, comforters, and the bumpers. So like we had talked about, the Consumer Product Safety Commission, they actually made the beds to where the slats are now a shorter distance apart, so a kid's head cannot get stuck in there. So that was the point of the bumpers, and so now that their head can't get stuck, you really don't need the bumpers in the bed. They're cute and everything, but they do pose a place where the kids can, if they roll over or if they get stuck up against it, they can suffocate. You can swaddle your infant. There's a little swaddling jacket. They've come a long way instead of just a blanket now. But you can stick their hands in each side, and then you stick them in a little blanket and you swaddle it. It's Velcro, so they can't get out. It's okay to swaddle them as long as they're not rolling. Once they start rolling, then they can get in trouble if they are flipping over. Now they don't have their hands to help push them up. So when they start rolling, you can use these sleep jackets or blankets. So this is a better option than a free blanket in the bed because it stays on the baby and it can't get over their head. And you don't want to use wedges or positioners because as much as these companies want to say that they decrease the risk of SIDS, there's actually 2 cases where they probably cause the suffocation and entrapment because these are made of these soft, comfortable materials, and so kids who, if they slip, can get stuck on it. If they can't raise their head, they can get in a bind there. So breastfeeding, we are a breastfeeding institution, and we care about breastfeeding. So the first AAP recommendations to reduce SIDS in 2005 actually didn't include anything about breastfeeding because at that time the studies were insufficient. But now we know a lot more about it. So breastfeeding is better for everyone, for moms and for the babies. It has many physical and emotional benefits from it. Until this study was done, it wasn't really well understood. So the physiologic sleep studies that show breastfed infants actually have a lower arousal threshold than formula-fed babies, especially between the ages of 2 to 3 months old. So that's important because that's also when SIDS is peaking. Another advantage to breastfeeding is that it provides IgG, the maternal IgG, and especially between 2 and 4 months of age when the maternal one from the placenta is decreasing and babies hasn't yet revved up. So the formula-fed babies aren't getting that, and so they can be more prone to infections. There's no infections that have been shown to cause SIDS. A lot of these kids, when they went back and asked parents, they said, oh, maybe a week or 2 ago they had a little runny nose, but it wasn't an illness that was significant enough to suggest that it caused it. They just had a recent illness. So this was a meta-analysis. This breastfeeding and reduced risk of sudden infant death syndrome was a meta-analysis done. They had 265 articles, but they only included 18 of them. And they showed that any breastfeeding for any duration had a pooled odds ratio of 0.55. And interesting, if they did exclusively for over just 2 months, then it reduces the risk by 70%. So that's something that we can definitely be educating and helping our parents with. If a lot of nursing moms nurse in bed because you're nursing all the time in the beginning. So actually nursing in the bed is one of the safer places if you're going to be possibly falling asleep. You want to nurse in a bed instead of on a couch or on a winged chair or an armchair, because if you fall asleep and the baby falls asleep, the baby can wedge against something. But in the bed, you can't have anything in it. So they say when they did this study, it was a bed that had no pillows, no blankets, no sheets. Mom just laid in the middle of a bed. And so that was the safest place for the baby, which is not what we're going to do, but that's when that's what this study had showed. So if you're going to tell moms if they're going to be breastfeeding in the middle of the night and likely to fall asleep while nursing or something like that right after, then to lay in the bed, but to move the pillows and all the blankets around them. And so parents need to be vigilant that if they do fall asleep, once they wake up, they need to put the baby back in their own sleep surface as soon as possible to help prevent the risk of SIDS. All right, so room sharing. This was new that came out in the October 2016 AAP recommendations on safe sleep. Infants sleeping in the parents' room in their own bed can reduce the risk of SIDS by over 50%. You don't want to place them in an armchair or a couch because this increases the risk of SIDS. And the risk of SIDS is highest if you're going to share a bed before 4 months of age. So when I was looking at the studies that they were using to suggest this, most of them were comparing it to sleeping in the same bed. So I was curious because with monitors these days, if they're sleeping in their own crib in another room, you can hear everything and you can see everything. So I was wondering if it was beneficial to keep them in the room. They talk about it that in the first 4 months you're there, you can be attentive. If you hear them stirring, you can get there faster. If the pacifier falls out in the middle of the night or something, you're closer to give them more attention quicker. But this risk is reduced when you compare it to sleeping in the bed with them, which is a no-no. So pacifier use, it's actually beneficial to offer a pacifiers. We can give it to our breastfeeding moms once the breastfeeding has been firmly established. Using it at night is helpful. It does decrease the risk of SIDS. Why? They don't really know yet. but it's only in the beginning when they're first falling asleep. You don't have to stare at the baby all night and put the pacifier back in when it falls out. If it falls out, it's okay. There's no studies that have been done on finger sucking, and you want to make sure that when our parents use this, they don't put them in the bed with it. This is the little cord that attaches the pacifier right here, so that way they can find it in the middle of the night or if it doesn't hit the floor or something, but this is something that can strangle the baby at night, so you want to make sure they're not using that on their clothes at nighttime. So avoid overheating. How many of our parents come in with their kids and you have to unzip 6 onesies to get to the skin? So avoid overheating. There's no set room temperature that needs to be recommended. You want to tell them not to cover the infant's head ever with any blankets or anything to try and keep them warm. And infants really only need one more layer than we need and when we feel comfortable with. So we can tell them, if you're in a light jacket, just put the baby in a little bit of a thicker jacket, and that should make them feel comfortable. They don't need 6 layers of clothing. And when they come in, they're like, my baby sweats all the time and they're hot. Well, they're probably overheated. They need to take some of the layers off until they cool off. So another way to decrease the risk of SIDS is to do a lot of prenatal care. So the babies that had the more prenatal care were less likely to die of sudden infant death syndrome. So encouraging them to go to the doctor and keep those appointments is important for them so that they can stay healthy throughout their pregnancy. Increased risk of sudden unexpected infant death is due to intrauterine exposure and secondhand exposure to tobacco, so that's a big one. The risk is even higher when the baby shares a bed with a smoker. So those of our patients that smoke, we need to tell them, we tell them to wash their hands and everything, but we need to tell them that the baby should not be sleeping with them under any circumstances, because this will double their risk of sudden infant death syndrome in this young age group. And so there's also increased risk if they've had any prenatal or postnatal exposure to alcohol. So alcohol alters the arousal threshold in animal studies, so it most likely alters the arousal threshold in the infants. And then there's studies that have been done on methadone, cocaine, heroin. All of these had an increased risk of sudden infant death syndrome when kids were exposed in the uterus and out. So immunizations, this is actually a level B recommendation by the AAP. So immunizations actually decrease the risk of SIDS by over 54%. This was a meta-analysis that was done on 4 different studies that showed this. It's not sure whether, we know it's protective, we know immunizations are protective, but maybe the kids that didn't get their immunizations were sick, and maybe that was why they might have not gotten their immunizations or something like that, instead of just plain old, I don't want to vaccinate. So telling our parents to get the immunizations that it can decrease the risk of SIDS will probably help encourage a lot of our parents to get it. So these cardiorespiratory monitors, they all say they can reduce the risk of SIDS and help you detect SIDS. There's actually no data that's been done to prove that it actually reduces the risk. Thankfully, most of the time that it goes off, it's a false alarm, it fell off the baby's foot. It does cause a lot of stress. There's been studies that have been done that it shows it causes a lot of stress in the marriages, in families when it does go off. I would probably be having a heart attack in the back room if it went off and not next to the baby's bedside, because it would scare me. So they don't have to have this. This is one of them that goes in the foot. There's some pads that go underneath the baby's bed that monitor respirations, and they have a new one that sticks to the wall now that detects their CO2 and their oxygen levels, and can detect their heart rate and their moving, and it actually tells you their quality of sleep. So I don't know if you really need that. So tummy time is endorsed. There's no set recommendations on the duration and frequency. In Wednesday Clinic, we tell everybody at least 3 times a day, 15 minutes a day. This will help prevent the plagiocephaly and the head flattening that comes with sleeping on their back all the time. It'll help them facilitate their upper shoulder strength, which is good for so they can reach their milestones, help them be able to push over, turn, roll, crawl. It's important that parents need to watch them. They can't put them on their stomach at 3 weeks of age and then leave the room, because we always tell them that the infants can't lift their heads up well on their own yet. So you need to be there to watch them, to help them out in case they get in trouble. And a lot of babies don't like tummy time, so you can actually tell parents, oh, my kid hates it. Well, make it fun. Get on the floor, look at them, interact with them, put a mirror there so they can look at their best friend, and place like bright toys, or make it fun for them so they stay down there. And they may cry and they may not like it, but it's good for them in the end. 10 minutes, 15 minutes a day, 3 times a day, it's not a lot. All right.
What about the dirty carpet and the floor?
Put a clean blanket down. Wash a towel.
There you go.
Yeah. So the need for sleep. So we're going to talk about why everyone needs sleep. So this is the American Academy of Sleep Medicine with the AAP who endorses this. This came out in August of 2016. And there's an expert panel that got together that made these recommendations based on a bunch of different studies and their experience and their expert opinion on how much sleep everyone needs. So less than 6 weeks, random. They're going to sleep all the time. You don't need to be stressing about it. You need to be letting the baby adjust to, the house. Mom needs to be recovering. The baby's going to sleep on and off. And it's important that they're going to take naps. Mostly everything is a nap at this age. And the longest is about 2 to 3 hours. So we can let our parents know that they're not going to be sleeping through the night at this age. 6 weeks to 4 months, they need to be getting 15 to 16 hours total. And so do they take naps? Yes. In the beginning, they'll take 4 to 8 a day. And then maybe the longest one, 3, maybe 5 hours. From 4 to 12 months of age, they need 12 to 16 hours of sleep total throughout the day in a 24-hour period. And now they're napping 2 to 3 times a day. When they're 1 to 2, 11 to 14 hours of sleep. They're napping once, twice a day, but mainly once a day. They're weaning that second nap. A 3 to 5-year-old, 10 to 13 hours of sleep a night. And they need a nap during the day, once a day. And then our naps disappear when they go to school from 6 to 12. They need 9 to 12 hours of sleep, and they don't take a nap. And then the 13 to 18-year-olds need 8 to 10 hours of sleep. So ideally 9 is the magic number for our adolescents. And they don't get a nap, even though this is the age that probably wants it the most. So why do we need sleep? So in this consensus statement, they went over why it's so healthy and why it creates healthy children. So metabolic health. Children less than 10 years old with a shortened sleep are at increased risk for obesity. And this is due to changes of glucose and insulin metabolism if they're not getting enough sleep. Mental health. There's no data for children under the age of 1, but there's a lot after that. In children, there's increased risk of ADHD if they're sleeping less than 8 hours a day. Teenagers have increased risk of suicidal ideation, ADHD, substance abuse if they're getting less than 8 hours of sleep. It's been shown that you need at least 9 hours of sleep to have adequate behavioral functioning. This is in school, this is just your behavior, your ability to adapt to your surroundings, 9 hours. And more than 10 hours could actually be a red flag for depression in some of our adolescents if they're doing it on a consistent basis. Some other reasons why sleep is good: cardiovascular health. If anyone's getting less than 5 hours, it increases your risk of hypertension. Immune health, if it's less than 8 hours, it's associated with a poor immune function, which is why when you stay up all night and you're studying, you're doing something, you get sick after because your immune system hasn't had enough time to recover. And school performance and development. Those with less than the recommended amount for age, based on any age, so our adolescents would be 9, the elementary school would be about less than 10, then they have worse school performance compared to those who sleep more. So the more you sleep, the smarter you can be. So we need to be telling our parents to get their kids to sleep. Healthy sleep habits can increase your attention span and your focus. It increases your daytime alertness throughout the day, and it helps them become more adaptable to the surrounding, and it decreases the amount of stress that goes on the body. So we're going to talk a little bit about our infant sleep training, how to get your kids to sleep. And throughout intern year, second year, third year, how many times do we have parents come in that say, oh, my kid eats every 1 to 2 hours, like all the time. A 6-month-old does not need to do that. He's probably tired. So we'll go through helping them be able to sleep. So there's a bunch of different books that you can read on how to get your kids to sleep. A lot of people use BabyWise, Healthy Sleep Habits, and A Happy Child we read in Wednesday Clinic. And then 12 Hours by 12 Weeks is one that I've known a lot of residents to use that have had some success with it. So we're going to kind of meld together all of these ideas and then what the AAP recommends in order so that we can be able to educate our parents on how to sleep. And this is just a sample that came out of BabyWise, just so you can see if they buy the book, it'll tell them, newborn, when to feed, every 2 to 3 hours. They're awake. This is what you do when they're awake because they're full, and then they're going to go to sleep. How many times do they sleep? So it's broken down based on their age from newborn to 4 weeks to 8 weeks to 12 weeks. And so this is something if you want to be able to tell them, if they want a book, you can recommend this because it has algorithms in there for parents. All right, so what do we tell our parents? So we start off with, as a newborn, they need to just feed on demand all the time. Don't worry about a schedule. the first 6 weeks are for the babies to get used to their, their new environment, their family, and for the mom to recover. So in the first 6 weeks, you just feed the baby when they're hungry, but you need to be feeding them at least every 3 hours around the clock until they've regained their birth weight. So we don't really want parents giving a 6-hour break if the kid's failing to thrive. So that's just a general guide that we can tell our parents. And it's important that they know that the feeds are measured from the start of a feed. It doesn't matter how long it takes the infant to feed. It's measured from the start. So they need to keep like a diary of when they started feeding, and then 3 hours after that is when the baby has to eat again if they're still sleeping. We're letting the baby adapt to their existing family, and you want to try not to create bad habits in this time frame. So bad habits would be, you feed the baby, you put him in the swing. And then you feed the baby and you put him in a swing. You feed the baby, you put it in a swing. Well, now the baby thinks that it has to go in the swing for all its naps and playtime, and so that's a bad habit to have to break. So you want to, obviously help the baby in any way you can, but you don't want at this age to be rocking the baby to sleep every single time, because now the baby needs to be rocked to sleep every single time. And it only takes 3 days for you to create a really good habit and for them to adjust to a good habit. And then if you get out of sync and go to your grandparents' house, it can take 3 days to break the habit, and then they get out of whack. But it takes 7 days to create a bad habit, and it takes 7 days to break it. So it takes even longer to break a bad habit, so you just want to try not to do that. And then at around 6 to 8 weeks, if they meet certain criteria that we're about to go over, then they're ready to sleep. So some of the criteria, they need to be at least 6 to 8 weeks old before we start talking to them about it. They need to be at least 10 pounds, so that they need to be documented that they've had good weight gain. They're not failing to thrive. They're not gaining weight and now staggering. They need to be documenting consistently good weight gain. And they need to be able to consume at least 24 ounces in a 24-hour period in order to start the sleep training process, because we're not trying to starve our little ones here. So steps. So step one, we tell the parents to be committed. So it's going to take time. It takes an extra hours now, but the gain is long-term. So it's really easy when the 8-week-old is screaming to feed it and to give it a pacifier, do something, but you want to try and not create those bad habits right now and do the quick fixes, because the long-term goal is there, I promise. And we need to start to create a routine. So the parents need to do a routine now. Babies thrive on a routine. It's great for them. A lot of our parents don't have routines. So a routine would be, when do you want the baby to go to bed? All right, 30 minutes to 45 minutes, however long it takes you, start getting the baby ready for bed. Do a bath every night. You can put lavender lotion if you want to, that they say helps with sleep. You can put on music, read to them, interact with them, but you want to dim the lights, and this is signaling to the baby it's about time to get ready to go to sleep. And so after a couple days, the baby's going to realize it's time to wind down. So the first step is just convincing the parents to stick with it. Step two, they need to be feeding at least every 3 hours during the day. Easy start. Breastfed babies tend to kind of eat more frequently sometimes. So the next goal for the parents is, okay, we'll get them to eat every 3 times throughout the day. Measure from the start of a feed. So 7, 10, that's when they need to be doing, and making it consistently. And then after they're doing every 3 hours during the day, you want them to do 4 hours during just a 12-hour period, which is most of the time daytime. So you want them eating during the day. So that's 4 feeds a day. So if you can stretch them to 4 hours. And then step 4 is, once they're doing that, they're eating every 4 hours during the day, they're consuming at least 24 ounces, they're growing, then you can start to eliminate the nighttime feedings. And so in order to be able to tell parents this, there's some tools that we can do, and every 15 minutes that you can get closer to the 3-hour stretch is successful. You can go backwards some days, but you want to keep moving forward. So even if the baby's crying and it's been 2.5 hours, if they can get 15 minutes by giving a pacifier, bouncing the baby, shushing them, walking them, that's a success. So if they do that consistently, it's gonna end up getting them to their goal. And so yes, the quick fix, like we talked about, would be giving them the bottle, right, that in there, but you can try and stretch them, and 15 minutes is not gonna hurt them. I mean, you can tell the difference in their cries if they're hungry versus if they're just getting irritated or just winding up. Of course, if the kid's starving, don't starve them. But we can help them, and there's some tools that we can use to help them do that. So the toolbox, what do you give parents? So there's a toolbox. There's a daytime toolbox and a nighttime toolbox. So if you want to, during the day, if you're trying to keep them up and you stretch them to their next feed, you can give them a pacifier. That'll always buy you 15 minutes, I feel like. Put them in a bouncy seat, put them on their activity mat, sing to them, play, bounce them on the knee, do tummy time, do anything that you can to help stretch them to the 15 minutes, and you can be getting the bottle ready in the meantime or getting prepared to nurse them. And then at night. So if the infant's waking up before their scheduled feed at night, then there's things you can do here. So these are the nighttime toolboxes. Give them a pacifier, pat them on their belly, tell them it's okay. You can shush them, sound machines, whisper in their ear that they're fine. Let them know that you're there, but you don't have to run and pick them up and feed them. And sometimes you can also use these nighttime tools when you're trying to stretch them and if they wake up before scheduled feed, or if they're waking up in the middle of the night and it's not time to eat and they're not going to eat for another 3 hours. These are things you can do because you don't want to always run in and pick up the baby, because then that stimulates them. And so at night you're going to keep the lights dim, you're not going to make eye contact with them, you're just going to let them know that you're there, reassure them. You don't have to fix everything, because part of this is letting the baby learn how to fix it themselves. And there's certain things the baby can't fix, like a poopy diaper. So once they're able to do that and the baby's now eating 4 times a day, you can stretch the nighttime feed out. So you need to be monitoring the duration between the feeds at night. Once the infant stretches the feed themselves, that's the new goal. And you can follow their cues and help them pace the feeding. So what I mean by that, if they go to bed at 7 o'clock and then they make it 5 hours, and they've been eating 4 times a day, they go to 7, they've made it 5 hours. That's the new goal. They wake up at 3, they've proven to you they can go 5 hours contently, assuming they ate well the bottle before, but you can stretch them. So try and give them a pacifier, try and shush them, pat their belly, try and get them to go back to sleep. And you want to keep trying that and try and stretch them to that 5-hour mark if you can. So yes, the quick fix would be just give them the bottle so that you can go back to bed, but then the baby's not learning to fix anything themselves. Sleep is the first discipline that kids learn. So you're helping teach them, just like you teach them to walk, we're teaching them how to sleep. So you're going to leave them in bed and they're going to eventually learn this quiet time. You always want to be prepared. There's nothing worse than getting the baby and realizing it's time to eat, and now the baby's screaming and out of control, and you're heating up the bottle or making the bottle. So try and have it at least partially ready if you can. Have the water in the bottle and add the scoops, something like that, so that way you're not letting the baby just get completely out of control and extra awake now, instead of just you want them to kind of sleepwalk through the feedings at night without getting too alert and too awake. Like we said, you want to keep the room dark. You want to avoid giving them eye contact. Don't do excessive stimulation. Turn on all the lights. Rip off their blankets and everything. And you only want to change their diapers if they're poop diapers. You can leave them in, a scant little pee diaper. Of course, if they're leaking over, then you need to change them. But the less stimulation you're doing at night, the better. So step 5 is, now that you're stretching the nighttime feed, like we talked about, if they go 5 hours, that's great. That's the next time you feed them is a 5-hour stretch. Eventually they'll go 7 hours, and that's the new goal, 7 hours between a feed at night. You're still waking them up every 4 hours during the day. We tell them to wake a sleeping baby during the day, because if you let the baby sleep 8 hours during the day, it's going to be up all night. So it's every 4 hours during the day, and we're pacing the nighttime feed. And I just keep reiterating that to parents, because I don't want them to think, oh, the baby can go 6 hours during the day, because now the baby's going to be up all night. So it's important to wake a sleeping baby during the day. Grandparents, my mother, don't ever wake a sleeping baby. I'm like, I will during the day, because I want her to sleep at night. And you want, now that they're stretching the nighttime feed, and they're going to go hopefully 10, 12 hours between a feed at night, they're going to be taking in more during the day now, because they're stretching their feeds out. The more they take, the longer it takes for them to digest it. The longer they're digesting it, that's what helps them stretch it out. So they should be taking enough during the day to make them content at night. So now you got to work on getting them to stay in the crib at night for 12 hours. And this is where your nighttime toolbox comes in, where you can go in, if they wake up, you can re-give them their pacifier, you shush them, tell them they're okay, and then you can step out, and then if they get frustrated again, you go back in, and you're just leaving them in there. And then in the morning, you want to leave them in there too, because the first time they wake up, if they're happy, you want them to learn how to self-soothe and play in bed. So you don't have to run in the very first time they make a noise in the morning. This will help them kind of learn that the bed's fun, and it's a great place to be, and it gives you time in the morning to get your stuff done too. And then step 6 is, once they're sleeping through the night and for 12 hours, then you can work on the daytime naps. And so we'll go over some of that. And so for daytime naps, most of the time when you're getting to step 6, you're at that age where they're about 3-4 months old, like the 12 hours by 12 weeks, you're there. And so they're sleeping at night, and now they should be getting 2 naps a day, 3 naps a day. And so it goes normally, their first feed is when they're the most awake. They'll be awake, then they'll play, so play for a little bit, and then they need to go to sleep. And they normally sleep for about an hour. Then they have their second feed. then they eat, they play for a little bit, and then they're going to sleep. And then that sleep might be 2 hours in duration, 2 to 3, depending on the age of the baby. Then they get their third feed, and from the third to the fourth feed, they're pretty awake. They're playing a lot more. They may take a 30-minute nap. They may take no nap here. You don't want a 3-hour nap here because they're well rested. They're not going to go to bed after the fourth feed. So for our parents that come in and say, I feed him in an hour, and then an hour later he cries, he's probably tired. So we need to try and talk to them and give them the education to look for the sleep cues that they might have to help them be able to get their infant to sleep. So what are the sleep cues? So you can tell parents when they're getting tired, they're going to be less busy. They're going to start kind of staring off. They'll be yawning, and they'll be calming down themselves. When they're cranky and they're rubbing their eyes and their eyes are red, now they're overtired. Now it's a lot harder to get them to go to sleep. So we need to be telling them to watch for these signs of them kind of winding down so that this is the optimum time to try and get them to go to bed, not when they're overstimulated and now overwired. So it's a lot harder to get them to go to sleep. So the cried out. A lot of people talk about the cried out method. Read a lot about the cried out method. You hear it's good, it's bad, you're going to traumatize your kids for the rest of their life. They'll never be the same. Or, you know, my kid cried all night long and never went in and he's fine. And so what can you do for crying it out? So for cried out, your job is to assist. You don't need to fix everything. It's okay if babies cry. This is kind of the limited crying method. There's a couple different crying methods. This one's limited, so it seems nice to parents. You let them cry for 5 minutes. You can monitor their type of cry. As parents, you can tell if something's really wrong or if they're just frustrated and they want some attention, or if they're kind of, you know, just grunting to get themselves to sleep. So you want to monitor the type of cry, and you're watching. And you want to time this, like Dr. Gill always says, by a clock and not by your heart, because it'll feel like an eternity after 30 seconds when your kid's crying. If they stop crying at any point, reset the clock, 5 more minutes, okay? Because they've calmed down, and now it's time to start the clock again if they start crying. After 5 minutes, you can go in, check on them, check on the baby. You want to, again, keep it dark, no eye contact, you know, you're looking away from the kid, and using your nighttime toolbox to try and soothe them back to sleep. And then once the baby settles down again, reset the clock. So this was interesting. I read this from a study that was done in Australia. So it's the controlled crying method. And so in this study, they have a whole sleep clinic that's dedicated to infants and sleeping. They created this controlled crying method. So if 5 minutes is too much and our parents want to warm up to the idea, night 1, first time they cry, you wait 2 minutes. They're still crying? Okay, then you go in, you fix them, you do your toolbox, you try and get them to calm down, they calm down, you leave. They cry again. Now you wait 4 minutes. And then you go do your thing, get them to calm down, leave. And then the third time you wait 6 minutes. So you're stretching them. You go in the first few times and now you're stretching them, and then every other time is 6 minutes. Then day 2, you go here, again, you follow the timing. And eventually, after a week, you're going to really be spacing it out. But you know, most kids should have adapted by now. You know, they might be crying for something that they can't fix themselves, like a poop diaper, or they peed, or they got stuck or something, so you're watching them for that. They actually checked the cortisol in the saliva. And yes, kids were stressed when they were crying, but they checked them again at a year. No increased cortisol for the rest of their life, back to normal. So you're not going to cause permanent stress in your child if you let them cry it out a little bit when they're an infant. Another thing, sorry, that was interesting, is that you let them cry it out, and then typically they said after a week, you gained 15 minutes of sleep time, and those infants actually woke up less throughout the night compared to those who didn't go by the controlled crying method. So if you followed this method, the kids went to sleep 15 minutes faster, and they stayed asleep more throughout the night, less nighttime awakenings than if you just went in every time they cried and didn't time it out. And so I just wanted to touch on our adolescents because, you know, we went over infants, we train our infants to sleep, but a lot of the portion is our teenagers that come in that have behavioral problems, or getting thrown out of school, or, you know, the ADHD that they want to treat. So we can't forget about our teenagers. So teenagers need sleep too. They're probably our worst sleepers. During adolescence, there's actually natural changes that occur to the body that cause the sleep phase to be delayed. So this causes teenagers to fall asleep later. They studied melatonin in a bunch of teenagers. Melatonin is actually secreted later in the night, and it turns off later in the morning. So it's harder for them to go to sleep, and it's harder for them to wake up in the morning if you're waking up before their melatonin is starting off. According to the National Sleep Foundation, drowsiness and falling asleep at the wheel with teenagers accounts for over 100,000 car crashes a year. And driving drowsy is actually equivalent of a blood alcohol of like 0.8%. So it's dangerous. And so how many teenagers do we know that are behind the wheels? So there was a campaign that started our intern year in 2014 that says all school start time should be pushed back because of all of these studies, but that failed, it didn't pass. And so we need to be able to help our adolescents go to bed earlier, even though that's not really their natural time. And so what can we do? So we need to talk about sleep hygiene with them. You want to keep a sleep routine and have them stay within 30 minutes of their bedtime. This also applies for waking up. You want them to wake up at the same time every day to help their body kind of train and get used to the sleep routine that we do for our kids, which is hard on the weekends when kids, the teenagers want to sleep till 11, but we want to encourage them to wake up at the same time every day. And we want to keep their room dark and quiet as possible so it's a relaxing environment. You want to tell them not to save their homework for the very end of the night, because you don't want them to be all stimulated and worked up and trying to rush and get things done at 9 o'clock at night when they should be going to bed. You want to tell them that the bed is only for sleep. Hopefully that's all they're doing in their beds. And you want to limit the amount of gadgets used prior to bedtime. So that's their phones, their iPads, their TVs. That light is stimulating to the brain and is not exactly telling the brain it's time to go to bed. So you want to limit that. If they aren't tired, they're supposed to be able to get up and read with dim lighting next to the bed, not in the bed. They should only be sleeping in the bed. And they want to limit the daytime naps to less than 30 minutes. Taking a nap for 30 minutes or 2 hours or 3 hours does not make up for inadequate sleep. So they might feel a little rested after that, but if they're still getting consistently 5 hours of sleep a night, they're at risk for all those things we talked about with heart and mental and their poor immune functioning. So it doesn't make up for not sleeping well. 5 hours during the day, 3 hour nap, it doesn't make up for it. So they really need to be consistent, sleep at night, and limit their naps to 30 minutes. And you want to tell them to avoid stimulants such as caffeine and nicotine prior to their bedtime, because that'll stimulate them. And then exercise daily. In this study, 10 minutes a day, that was it. Help them sleep a lot better at night and help them wind down and get ready for bed. And you want to tell them to avoid big meals right at bedtime because you don't want them to be digesting their food while they're trying to go to bed, because now their gut's awake and releasing hormones and enzymes, and so it's going to rev them up as well. And so as a summary, so as pediatricians, we need to do our best to help educate our families on ways to reduce the sudden unexpected infant death syndrome. There's far too many infant deaths each year that can be prevented. 46% of all of the 3,500 deaths are because of SIDS, which is unexplained. And so us being able to tell them to limit the stuff in the bed, put them on their own surface, keep them in there, and all the things to avoid, and do tummy time during the day, don't smoke. All those things can be protective that we can tell them that they can do. Sufficient sleep is important for cardiovascular health, their mental health, their immune function, and their school performance. And there are various methods that you can do. You can pick up any number of books to help get your kids to sleep throughout the night. But I feel like in our patients, it's good to give them a stepwise progression, because then, they can do one at a time. And then the goal is to get them sleeping throughout the night at 12 weeks of age to 4 months of age. So that 12 hours at night, not just their 6 hours. A lot of times our parents say it's 6 hours. Ask them what time they go to bed. Midnight, they wake up at 6. That might be full enough sleep for you, but that's not enough sleep for the baby. And so adolescents have a delayed sleep phase, making sleep hygiene essential for their school performance, for us to be able to get them to go to bed earlier. And then sleeping through the night at 3 months of age is possible. So, do y'all have any questions? Did that bore everybody?
Question? So when you start, I know when you're discharging the baby from nursery, your focus for the parents is having this baby sleep on his back. So when do you start the discussion with parents about sleep hygiene and sleep training?
So when they come for their weight check after the newborn nursery, I'm normally saying, especially with their breastfed baby, just feed on demand. You need to wake them up at least every 2 to 3 hours. Everybody does it different, so that they're not sleeping these long periods, so they're gaining their weight. And then at their 2-week checkup, if they've typically documented good weight gain, then I can say, okay, you still need to set your clock during the day to every 3 hours, Because if they go 6 hours during the day, they're going to be up all night. Because so many of our parents say their kids up all night. Well, it's because they slept for 8 hours during the day. So I tell them during that 2-week visit, every day, 3 hours, and then at night, if they've documented good weight gain, they can not turn their alarm on and let the kid wake up and pace themselves at night. And then at 2 months is when we say, okay, are you ready to start the sleep training, assuming they've hit all their criteria and they're gaining weight and they're 10 pounds and they're the right age.
Perfect. Okay. Other questions? Comments? No, thank you, Elaine. That was great grammar.